treatments were behavioural, environmental, social, and system interventions, social distancing, masking, reducing sort of capacity buildings. So there's a huge amount where societies were leaning on BESSI type interventions. But in contrast to, say, the basic science or the clinical science, there was actually very little research being done in real time about how BESSIs could be optimized to support societies to address a pandemic. And we from an early sort of, in the first year of the pandemic, less than 5% of the global COVID-19 research budget was focused on BESSIs, and that just indicates how little funding and support was in this area. If we look at if we look at what one of the implications of this are, BESSI research needs to use many different methodologies, but this is just a scorecard that our colleague Paul Glasgow has been maintaining, where he's been looking at randomized controlled trials of in the COVID era. And to date, there have been over 2,500 drug trials registered, but only 18 BESSI trials. So I think this sort of disproportionate amount of, or the fact that so few BESSI trials, again, indicates that there's a major problem here. So BESSI's role is really to try and think about how can we do better? And it's not just for the pandemic, because beyond the pandemic, existing infectious diseases, whether they're endemic, seasonal or periodic outbreaks, remain a major cause of morbidity and death globally. And so BESSIs are also the main defense against different infectious outbreaks. And we need to develop a BESSI research agenda to improve response to the current pandemic and prepare for future outbreaks. Some of the challenges we've got is that BESSI research is inherently interdisciplinary. If you attended our first webinar, which focused on a Cambridge study looking at HEPA air filtration, that required ventilation engineers, clinicians, health services researchers, virologists, all coming together to work in a team to address that issue. And it's often very hard to build these interdisciplinary collaborations in the heat of the moment. So that, you know, what we need to do is find ways in which we can build the community of BESSI researchers around the world, encourage that interdisciplinary thinking and approaches, and starting to work together with outbreaks, so that we can sort of basically be ready to mount a better research response in the future. So moving on to the webinar today, we're delighted to welcome three great speakers. John Kinsman is going to present some work that he's been doing looking across governments about how they have used social science and behavioural science inputs into their COVID response. John is an expert in social and behaviour change. He works at the European Centre for Disease Prevention and Control, which he joined in 2019. Where he's going to work on issues related to social and behaviour change in vaccine and prevention of antibiotic resistance. The pandemic struck the second year, which probably changed his work very considerably. And since then, he's been focusing almost exclusively on the response, with projects on addressing pandemic fatigue in the population, how to support social vulnerable populations, preparedness and implementation support for COVID-19 vaccines, and countering online vaccine misinformation. I've just realized I've got the wrong slide up here, but that's okay. So John is going to give us a broad overview about what different societies have done. And then our discussant, we have two discussants. One is Marijn de Bruin, who's a professor of behavioural medicine and health psychology at Radboud University Medical Centre in the Netherlands. And the second is not Professor Susan Meeke, it's Professor Molly Byrne. Susan had a clash, and so Molly was very happy to step in. And Molly is a professor of health psychology at the National University of Ireland in Galway. And they're going to really talk about what happened in their individual countries as we move forward. So I'm going to end my slideshow there and hand over to John. So John, do you want to take over?
Thank you very much indeed. Let me just see if I can now also share my slides. This is the one here. Bear with me for a moment. Do you see that okay?
Yep.
Okay. There we go. Now, I'm never quite sure with this. If I do this, can you still see everything and hear me okay?
We can see everything.
Perfect. Yep.
Good. Thank you. So I don't see any of you. So if anybody wants to say anything, then jump in, because I'm talking blind now, as it were. So thank you so much. And thank you.
Just so you know,
Yeah.
I'll also monitor the chat box and hands going up.
Okay,
So
great. Thank you.
I'll run that for you. And if people got questions that they want to ask during the talk, given we're a small group, I think that's okay. But also questions you want to ask at the end in the discussion, then also just put them in the chat box, and I'll keep an idea about that.
Absolutely. And once I leave the slides, then I'll be able to see you again and everything like that, and see the chat. So, okay, thank you so much, and thank you very much for the invitation. It's a fantastic opportunity to be able to talk with you all. I know a very high-powered group of people. So what I want to do is to talk a little bit about some of the issues that we have encountered from ECDC's point of view, from the EU's point of view, in terms of trying to promote behavioural sciences and BI for the different governments across the EU over the course of the pandemic. So first of all, in case you're not familiar with ECDC, we are an EU agency, so we work for the EU. We serve the Commission and we serve the member states. So our task is really to provide guidance and support for the activities that they are doing, and specifically the European Centre for Disease Prevention and Control. There's no P in there for the prevention bit, but it probably ought to be. What we do is all about infectious diseases. So we don't do NCDs, it's all infectious diseases. And there are a number of different things that we do, and I've listed several of them here. Surveillance, which is really, really core, and that's really what the sort of preeminent capacities of ECDC revolve around, and alongside epidemic intelligence, preparedness and response, microbiology, training, and then MyBit, which is social and behavioral insights, and health communication. So what we have done over the course of the pandemic, a lot of the work has been in other areas has been deprioritized, and we've provided a lot of input on COVID-19 response to the member states over the course of the last 2 years. So what I want to do to sort of kick off here, I want to talk about a survey that we did in the end of 2020 and the beginning of 21, notably pre-vaccine rollout. In other words, that's an important sort of point to bear in mind, when it was becoming clear that we didn't really know very much about what the different countries were doing in terms of behavioral insights or BI. We have systems in place for how we reach out to all the member states. There are very particular protocols that you follow. You don't just write to your friends. You have to go through certain nominated people in each country to do different activities. So we wrote to the relevant people in all of the then 31 countries. That would be including the UK at that stage. So we've got 27 EU countries and 3 EA countries, which includes Liechtenstein, Iceland, and Norway. And it was quite an effort to get people to respond to this. In the end, after 4 rounds of reminders and gentle shoves, I got 10 people to respond. So 10 countries took part in the end, out of the 31, which I think in itself is already an indication of something, which may be that we don't know exactly who the right people are to talk to, or it may be that it's not a particular priority in the countries. I'm not quite sure, and that's conjecture, but it definitely tells us something. So here we've got the 10 countries that did take part. You can read through them there. Cyprus, Denmark, Finland, France, Germany, the Netherlands, Norway, Slovenia, Spain, and Sweden. And straight away, you can see, if you kind of map that, and I'll show you a map a little bit later of where these all are, you can see that there is a bias towards the north and the west. Again, that's an indication of something that we need to think about. So what we did was to talk to the experts from the, and by the way, Marijn was one of the people I spoke to. He was the representative from the Netherlands. And we wanted to understand how BI findings have been integrated into decision-making processes during the pandemic. So overall, remember, of course, this is just 10 countries, but I can give you a snapshot of what we found. The predominant research has been quantitative, using serial cross-sectional surveys, which of course has the advantage that you can then see trends over time if you have nationally representative samples. that's clearly the advantage of that. Some qualitative research was being done, but not very much. And I'm an anthropologist myself, so to me this is something which I think is important, and it's a gap that we need to be looking carefully at to see how we can fill that. Why was it not being used in limited capacities in many countries? It's time consuming, and the resources and staff were not available for that particular work to the extent that, for example, the quantitative work was. 4 of the 10 countries used the COSMO tool, which has been developed by WHO Euro. And COSMO was a COVID-specific survey tool, which was developed by them for use by the WHO Euro member state, which stretches all the way to the Pacific, actually Vladivostok. So all of the sort of countries from the EU, East, covering many different topics. And the topics changed over time, of course. It was initiated in April or March of 20. And so, of course, as vaccination came in, new questions were added and some questions became redundant. But at this stage, when we did the interviews, the most commonly studied area that the countries were looking at was to do with population acceptance of and compliance with or adherence to the NPIs. So to what extent are the findings actually going through into the decision-making process? Excuse me. Well, what we noticed with the 10 countries was a real spectrum. In some cases, it was the right people were sitting at the table, and in other countries, it was extremely difficult to get behavioral insights findings actually into the process of the decision makers' thinking. In many countries, the problem was that BI was not really very well integrated into the management teams. And the social and behavioral scientists were not really represented to the extent that many other areas of expertise were, and clearly the predominant areas. And I don't think this would be much of a surprise to you, but it was extremely clear from the interviews that this was the case in the countries that we were speaking with. There were in several countries different institutions at quite high level doing different behavioral insights work. And for example, you could have one country where this sort of work was being done by the Ministry of Health, by the National Institute of Public Health, and by the President's Office or the Prime Minister's Office. So high level work being done, but not always coordinated, which is then problematic because you don't really know which data are being used, and would there be cherry picking or would there be a way of bringing everything together so there's a really good kind of synthesis of what's going on. Of course, we also found many of the countries funding a lot of COVID BI research in the universities, but once the money went out and the researchers are doing the work, there wasn't a clear avenue back to the decision makers. So there's a big problem there in terms of good data supported by the country, by the country's own bank, but it's not being used because the mechanisms were not in place for that purpose. So these were clearly issues to do with information finding its way to the right place. And I noticed also over discussions over the last year during 21 and to some extent this year also, that things have been improving. So I think the pandemic has actually stimulated more coordination and more bringing together of different data, but still we clearly have a long way to go. Here's the map I mentioned. The red countries are the countries that took part, and you can see it completely over to the west and to the north with an almost clear absence except for Slovenia and Cyprus towards the southern and eastern side. So that tells us quite a lot, I think, and particularly last year towards the end of the year when we had an extremely high level of infections in, for example, Bulgaria and Romania with very concomitant, very low levels of vaccination. It's quite clear there's a need to understand in much more depth the reasons for that low level of vaccination. For sure, a lot of it has to do with access, but equally for sure, a lot of it has to do with misinformation and general reluctance on the part of the population. So understanding that, however, was the understanding of that was very limited. So what we have here on this kind of shadow area towards the east and central side of Europe is a higher need, but less capacity in terms of behavioral insights, which is something that we as the EU we were very concerned about this, and so we were really focusing on this. And again, right now with the Ukraine crisis, you can see the 4 countries, EU countries that border Ukraine: Poland, Slovakia, Hungary, and Romania. These are also countries that we're now very much focusing on to try and provide more support to them in understanding the needs of both their own populations with vaccination, but also the people coming in from Ukraine who are under-vaccinated in many respects, and now we're particularly concerned about outbreaks of measles and possibly also polio. So, to what extent has BI actually contributed to decision-making? It's, again, not surprising to you, I'm sure, but it's very, very difficult, if not impossible, to really quantify this. To actually have your findings and your decision, there's a big black box in the middle, and to say the extent to which this is fed in is very, very difficult to say. But I think what we can conclude, and what we have concluded, is that the behavioral insights in many countries has often provided a nuanced understanding of how things are happening and how people are acting and understanding the situation. And therefore, implementation plans have been facilitated, let's say. There's been a particular policy that has come out specifically of a particular finding or set of findings, but rather that implementation has been improved. Operational plans have been made better. Also, looking retrospectively, BI has acted as an evaluation tool in the sense that you can see something as a policy has come in, and then you can see how the population has responded to it. So it's been more retrospective rather than formative in the sense that it defines the policy and then moves forward. And of course, this is where I think a lot of your focus is here. Are we looking at process or are we looking at impact? And I think we can conclude that BI has done very well in providing an understanding of process, which NPIs the populations are willing to accept, to what extent are the people adhering to the measures, and how can vaccination coverage be optimized? 3 of the core issues which clearly have happened. So that, let's say, process has been good. But if you're trying to say this NPI works, or this NPI doesn't, or this one is more effective than this one, excuse me, it's much more difficult to actually ascertain effectiveness. And here we're relying on the RCTs, which I've listed here some of the problems as I see it: time-consuming, expensive, logistically challenging, ethically sometimes problematic. And what are we actually assessing, the efficacy or effectiveness? There's also the question of to what extent would an RCT conducted, say, in Galway be relevant in Budapest? The results of that would be meaningless, potentially, because the cultural context or the political context is so different in Budapest as compared to Galway. The trust issues may be completely different in terms of what people are listening to and believing in from what they're hearing from the authorities. So it's a really, really big problem using the findings from RCTs from one context and applying them in another. And this is, I think I'd be really grateful for some discussion around this, because I think this is a big problem. And in fact, it's the same slide that appeared at the beginning of this, which I thought was really interesting that you also wanted to show this, because to me this says a lot. It says, first of all, these topics are much more difficult to do using RCTs, to evaluate using RCTs. And secondly, of course, the capacity to do that isn't there, as you pointed there at the beginning. So effectively, we have some sort of methodological bottleneck. The contrast here between the drug trials and the BESSI trials is enormous. Obviously, RCTs were designed for drugs; they weren't designed for behavioural interventions. And I think that's we have this sort of very often this thinking, well, we must apply the RCT to behavioural interventions, but I think it's and to just make that simple leap from one completely different type of intervention to another. And I think this figure really illustrates that. So what we need to, perhaps my proposal would be to be thinking about here, if we're looking at a sort of methodological wish list, we really need to be looking at other methods for evaluation. And I've listed here realist evaluation, which I recognize is quite complicated and it requires a very particular skill set to be able to do it, or operational research, which is essentially the science of better improving things again. But really we need methodological innovation. We need more inclusion of methods that specifically take context into account, and part of that, of course, can be brought about through qualitative data. And we also need much better collaboration between academia and the National Institutes of Public Health. Another big issue, of course, is getting the ear of the people who are making the decisions. How do you get to that table? And one of the things we found from these discussions with the 10 countries is that the right person isn't always there in the right place at the right time. And there are certain individuals we spoke to who were able to maneuver themselves into exactly the right spot. They have strong understanding of BI, they're well connected, and they're politically savvy. And they were able to maneuver themselves and get in, but that's not always the case in all the countries. So therefore you might have good work simply not making it to the table. Another issue we need to think about is the hierarchy we're working within, which is that essentially we are low on the hierarchy in terms of where we sit with regards to the epidemiologists or the immunologists or the virologists. I think we all know this. That's the fact. And I think therefore what we need to do is to raise our game even better, so that what we're doing is very solid, very convincing, and above all actionable, not fluffing around with, oh, it could be this or it could be that. I think we have to slightly avoid the hedging, and we have to be quite committed about what we should be doing, because decision makers want answers. They don't want more questions and problems to think about. And that, I think, is a problem, because we're always dealing with context and nuance and all this, and that is, again, methodologically very challenging, but we need to think about that. And another thing we need to think about is, especially during the pandemic, which was very, very exhausting, because we were constantly moving into uncertainty and fresh uncertainty and fresh uncertainty again. So what, as I say here, what I thought I knew last month is no longer relevant, or is it? I'm not quite sure. A new intervention, whether it's vaccination or something else, a new variant of concern, a new wave. So constantly changing situation, constantly not knowing what we should be doing. And our task as behavioral scientists, I think to some extent, is to help decision makers deal with that constant uncertainty. Now, the apparent passing of the pandemic. We've seen in many countries, sadly, a lot of COVID infrastructure is already being dismantled. Obviously, it's expensive, but I think we all know that the pandemic is not over. We're in, as the WHO Euro head, Hans Kluge, said, we're in a ceasefire at the moment. And there will surely be new variants. There will probably be an upsurge in the autumn. And yet we're now flying blind. Testing capacity is going down, sequencing capacity is going down, BI capacity is going down. And of course, our problem is, since we're relatively low in the hierarchy, is that it may be more difficult to get BI capacity and infrastructures rebuilt in the event of a new wave or a new VOC. So we need to be absolutely hammering at the door to make sure that what we have built now remains to the extent that we can keep it. The structures and the capacities that we build have to be institutionalized to the extent that it's possible. And as I say here, before the next crisis, well, unfortunately, it's already too late for that. We're already in the next crisis. And of course, decision makers' attention is therefore very much on that. But to avoid that loss of experience and skills, we need to do what we can to make sure that our voices are still heard and that we still have the work that we can do. So 4 things that I think we need to do now. Number 1, document and demonstrate what we've actually contributed to the pandemic response to date. We need to show that we've actually really contributed here in very real terms. We need to institutionalize capacities so we don't lose the expertise and infrastructures. And I think that's largely dependent on the extent to which we can do number 1. So the money and the resources will continue to come. We need to address disparities in the capacities across the EU. As I said, the Central and Eastern European countries have clearly got problems in not having as much as many other countries do. And we also need to think carefully about methodological development for the evaluation of behavioral interventions. And that was what I had to say. So thank you for listening, and I warmly welcome any questions.
Wonderful, John. I think what we should maybe do is take Molly and Marijn, and then we'll have sort of hopefully 20 minutes for sort of discussion across all of the areas. I have to confess, as you're talking, there are some things that I get very excited about, and other stuff I completely agree with, and I think that shows the sort of the value of having a very interdisciplinary perspective in this approach. The order I thought we'd go to is maybe Molly first, because I see Ireland as a country that was very quickly out of the gates in terms of sort of trying to bring behavioural and other insights into their policy, and then Marianne. So Molly, do you want to maybe give us sort of 5-6 minutes sort of discussion about what happened in Ireland for us?
Yeah, thanks very much, Jeremy. And thank you, John, for that excellent presentation. Really, really interesting. And I'd start off by apologising that Ireland was not there. I'm not sure how that happened, but maybe we can talk about that offline. So my name is Molly Byrne. I'm Professor of Health Psychology, and I'm here, like a number of other people on the call. I've been involved in the national response, in my case in Ireland, to the COVID pandemic. So as Jeremy has hinted there, Ireland certainly back in March 2020 responded incredibly quickly and I think incredibly well to the challenges of the pandemic. So I was a member of the Behaviour Change and Communications Advisory Group, which was established as one of 11 advisory groups back in March 2020. So we were tasked with advising the core national public health emergency team who advised government. So we were kind of 2 steps off advising government. We met on a weekly basis. We were a group of about 10 behavioural, social psychologists, health psychologists, health economists. We met on a weekly basis, did a mix of activities, including some primary research, most of which was led out of our behavioural research unit at the Economic and Social Research Institute. So they had a little team there who were dedicated to a range of survey and experimental methods. So for example, they conducted some really interesting online experimental research to develop the COVID communication tools, trying to target the right predictors of for example, social distancing. We also then, so when I say we, this was really led out of the Department of Health. They conducted or commissioned a weekly nationally representative survey, of which the findings were published online every week. And I mean, this was just incredibly useful at pinch points throughout the response to the pandemic. So where the politicians were coming under pressure, for example, from, business interests, to, who would say, well, everybody wants to open up again. We had this really rich data set which showed, well, no, actually the majority of the population are actually quite happy with the level of restrictions, and actually, if anything, want more restrictions as we went along. So that was an incredibly important source of data. Interesting, John, to hear you say that there was very little qualitative research. The team within the Department of Health actually carried out quite an extensive program of qualitative research in which at different points across the pandemic, they targeted particular groups. So for example, I'm aware that in particular with young adults and maybe even teenagers, they did quite a lot of qualitative research, and that really spilled over, I suppose, into an approach where we had young people developing materials for other young people, which I think also was very effective. So that group met, as I say, on a weekly basis. Our chair then fed into the National Public Health Emergency Team. So I suppose what worked well, I think the majority, I feel, and again, John, it's this question of, how you evaluate this at the end of the day, which I do think is a fascinating and really important question. The sense I get is that certainly the majority of our recommendations were taken on board. There was one blip, which was coming up to Christmas in 2020, when our politicians went all soft and said, well, people are the public are the best people to decide who they want to spend Christmas with. And it all went a bit loose. And then there was, like in many European countries, there was serious consequences to that bad decision, I feel. But on the whole, the majority of our recommendations were certainly taken on board. As I say, we great data, which was really taken into account. I think there were really good engagement strategies with particular groups, such as the young adults, also older people. So they got quite a lot of interaction and stakeholder engagement from groups of older citizens who really kind of rebelled against the original, cocooning approach. So it was just, there was some really good stuff going on with those types of groups. Another thing I think that was really successful, and this probably wasn't only with behavioral science, but across other scientific disciplines, was the high level of engagement with national media. So people within our team were writing frequently for the paper, speaking on the radio, being interviewed on TV. And there was a huge appetite for this. And certainly our public broadcasting authority were superb in this regard. So they were all the successes. I think the failures were, or problems were, even though I feel we did well, there was no behavioural scientist on the core NEFIT, so the core public health emergency response team. And I think had there been, I think it would have been better. I also can really relate to the problems you've raised there in your final slides, John, around there have been no structural changes now made to how behavioural science advises government as a result of the pandemic. So from the outset of the pandemic in 2020, you had 10 people who gave freely of their time every Friday. I did not miss one meeting for a year and a half. If we were to go into another period where those kinds of demands were made again of people, I don't know what the response would be, and it has not been brought into the infrastructure. So I think one of the things about a country like Ireland is it's actually very small. So I was asked, because people were aware of who I was, as were similar other people on the, on the team. So it was all done in a very informal way, which is great when that works well and when there is a real emergency. But I'd be interested just to hear from Marijn, because what my sense I get, Marijn, is that the Netherlands was kind of slower to kind of boot up, but it sounds now like you've probably done a better job of bringing it into more mainstream infrastructure, which we have absolutely not done in Ireland. And I think that's a real shame. So I'd be really interested, particularly, John, in this discussion around how we evaluate how we've done. So Jeremy introduced, me as saying, in Ireland, we've done really well. I mean, everybody in Ireland thinks we've done really well. And certainly on some of those, kind of WHO markers, I think we have done well. But I really have no way to quantify or to really kind of objectively report that in Ireland, behavioural scientists have done well in their contribution to the pandemic. And I would be delighted to collaborate with others in trying to develop something in that space. So thanks, Jeremy.
It sounds like Molly has passed the baton on to you, Marijn. So bring it home.
Yeah, bring it home. So yeah, the first infection in the Netherlands was in February the 27th, 2020. And in March 2020, we started the Corona Behavioral Unit at the Public Health Institute. So there was the Public Health Institute, there was a structure in place, a crisis structure for outbreaks. Then there's a formal advisory board that's called the Outbreak Management Team. It's chaired by the Public Health Institute, but it includes a lot of medics from across the country and epidemiologists. And that has been the composition of this outbreak management team. And the outbreak management team has the formal role of advising the cabinet for their response. So they formally advise. And throughout the whole pandemic, this outbreak management team has remained biomedical and epidemiological. Of course, there's doctors in there who work a lot with patients and also with vulnerable groups, etc. So they're not disconnected from society in any way, but their training is primarily biomedical. Nevertheless, we were able, through networks and initiative by a few people, to start a new department at the Public Health Institute, and we did that within a month, basically. And then within a month of launching it, we had received €1 million in funding. We developed a survey. We set up a scientific advisory board of 15 independent professors, behavioral science, sociology in the Netherlands. And we had our first 90,000 respondents to the survey. So that was like working 18 hours a day with a very dedicated team to set it all up. We broadened that to include qualitative research. So every time we did a survey, we followed up with qualitative research. We had a qualitative cohort and ad hoc an additional 50 or 60 interviews on dedicated topics. We looked at adherence, psychosocial determinants, well-being, support for policies, these type of constructs. We had very regular measures, so they were also a very important part, a backbone of our recommendations to policy and communication. And we've done online experiments, choice experiments, but also pragmatic trials. So when new policies were introduced, we were able to compare sites or manipulate some things so we could compare it. So in terms of translation, so we were not part of this outbreak management team. But I was in a regular meeting of the response team, it's called, and there's basically it's a lot of these epidemiologists and infectious disease experts are also in that response team. We discuss basically weekly the science, and it's a 2-hour meeting, and I always get about 15 or 20 minutes to discuss our findings and recommendations. We had a very close collaboration from the start with the crisis communication structure from the government. So there's a department in the crisis structure, and they advise for the press conferences, for the national campaigns, for the websites and everything. And we've been reviewing the websites. We developed a coding tool. Every press conference, we gave behavioral advice to the speech writers. And we reflected on a lot of the national campaigns. We also had quite a lot of contact with regional and local policymakers and communication professionals. So we gave trainings to the G4, that's the 4 big cities in the Netherlands. The communication professionals came to us, we want to do campaigns, can you help us out? And then we basically did workshops for them. And every 6 weeks we had new results, and we organized seminars. And there were most of the time between 80 and 100 professionals attending those. So there was a lot of indirect effects. We weren't formally asked to comment on upcoming policies up to January 2021. And from that moment onwards, we received the upcoming decisions, the scenarios that were on the table, like on the Tuesday. And then they required our input on the Thursday, the latest. So what we always did is that we pulled all the literature together, all our data, and then we had an expert advisory meeting with about 8 to 10 external people, again, sociology, ethics, psychology, people in different professional organizations. And together we sort of reflected on that, on the question, on the data, and then we gave recommendations. And that was given in writing to the policymakers. And then we had 2 once-off events. One was that I was in a parliamentary committee in front of the parliament, and another time in a cabinet meeting. But again, the chair of the outbreak management team was always in this cabinet meeting, advising on the epidemiological situations and what measures could be how effective. And we as representing the behavioral science were in there once, but there was also, we also have we call it Sociaal Cultureel Planbureau. So that's another, it's not the Public Health Institute, but it's more a cultural and social research institute. And their director was quite regularly in those meetings. So, so from all that, I sort of made a brief synthesis of lessons learned, but I'm probably already chatting for 5 minutes. So, so I think I'll just leave it because I don't want to take up too much time from the discussion.
That's great, Marijn. And if we get a chance, we can give you an opportunity at the end just to give any final reflections. So we've heard 3 very, I think, interesting perspectives. John providing us a sort of international overview, and then Molly and Marijn talking specifically about the experiences in their countries. there's been relatively little sort of in the chat box, but does anyone have any kind of questions or comments for any of John, Molly, or Marijn?
Well, I have a general
Actually, hi, welcome.
So
Do
to say.
you want to introduce yourself just so people don't know who you are?
Yeah, hi everyone. So my name is Matti Heino. I've been part of our behavioral advisory group for the Finnish Prime Minister's office. It's a different group than what John's interview round was consulting. So we have in Finland, we have this National Institute of Health and Welfare, where the person who the ECDC interviews included. And then we have a group that was founded in 2024 to give behavioral science advice to the COVID related matters, so to say. And we kicked up a survey that was done monthly. But something that I kind of struggled with all along this way has been like, what are the actionable insights that we can take away from the survey? So what we've been doing is that, okay, so there's it's basically a very non-behavioral science summary that here are these questions, and there's a really shortened version of the survey that gets sent to the ministries and all of those people, which just summarize that. So here are people answered this and this to this and these questions, and we've now had some research projects sort of that we did in the end of 2021, when we conducted like interview study to supplement that survey in terms of like figuring out what people say that they are willing to do and what they consider not that acceptable, and so forth, about this self-performed COVID measures such as masking and all of that. And that I felt that was a very successful thing where, because our prime minister was all the time saying that people are too tired of restrictions and we need to get rid of restrictions. And we sort of pointed out that restrictions is not a homogeneous category that we need to just get rid of. And people are not really tired of everything. They're tired of reducing close contacts and not that much like masks and all of that. But on the other hand, our the Institute of Health and Welfare, they have been, on the other hand, giving sort of different messages about, so for example, in the last few months, there has been this consistent message that nothing can be done, and which is something that I think we should somehow like coordinate with these bodies that do this sort of work. That is it really the case that we have done all we can, because it doesn't really look like that from my perspective. And so now we are actually trying to keep up the momentum when people's interest towards COVID has been waning. We're still keeping up tabs on COVID, but we've been moving to, so now we have a similar research project where we do qualitative interviews and we do the survey, and we do it about crisis preparedness. So relating to the Ukraine crisis, so we look at, okay, so how long, we have this national recommendation about that you need to be able to be on your own for 72 hours if there is sort of, for example, a prolonged electricity outbreak. But people don't really, many people don't know about that and so forth. So we've done a project around that, and that is also something that creates sort of resilience if we have the doomsday variant coming around and people need to sort of take a time out, and many other scenarios also. So we've been looking at this crisis preparedness, general crisis preparedness towards many generalized crises. So yeah, so I think that's something that can also be used to keep up the interest towards this behavioral insight that we can actually provide these things that come in handy with pandemics, but also in other adverse scenarios also.
So Matti, thanks. I think you're referring in your, you've addressed multiple topics. How do you keep it on the radar, the behavioral science and the pandemic fatigue narrative that we've all faced, I think, and how do you translate behavioral insights into concrete, actionable recommendations for policymakers? And I think that touches upon some of the other things that were discussed also by Molly and John and Jeremy at the start. And so if at the survey level, what we've done is that we've looked at the literature on similar types of findings. If you find out that there's motivational issues or there's accessibility issues or social norm issues, and that you look at what maybe Jeremy calls first principles, sort of the principles from theories, the behavior change methods / techniques type of stuff, and these intervention principles to actually provide actionable evidence. But on the slide that I didn't show, one of the complexities that we experience is that many of our the questions that play and then the recommendations that you give, that they need to be given within, you know, a matter of a week or maybe 2 or 3 weeks, because things are moving so quickly. And many of the behavioral interventions are multi-layer. So you want to have probably a communication aspect in it. You want to change something in the environment. You want to engage maybe employers in the process. So it's often a multi-level intervention. And what we notice is that the government, at least, is that they have a communication department. So, you know, behavior is communication often. So we've been communicating all the time. There's also context, you know, and there's also social norms and control and other environmental actors that you can involve. But if you give a recommendation to better support testing or to better support isolation or something like that, you're proposing a quite complex intervention usually, compared with, well, just shut down all the restaurants, you know. So how do you reflect on the complexities of voluntary behavior interventions?
So could I maybe, sorry, I need to interject. Maureen Smith has put a comment in the chat box, which I think starts to talk about this a little bit. And for those of you who don't know Maureen, she's just, Maureen, do you want to actually sort of just introduce your comment? But Maureen's one of our amazing citizen leaders in Canada. So Maureen, why don't you ask your comment / question?
Hi everyone, I'm crashing your meeting because I'm working with Jeremy and Justin Presso on these behavioral insights, which I've been interested in since the very beginning of the pandemic, and I'm providing a citizen perspective on the work that we're going to do with 3 public health units in Ontario. So I guess my question is, you know, it's always been important, but it was never acknowledged really, or wasn't much acknowledged. But now, do you think that the general public is able to actually see the behavior changes that people are having with this switch from the we're all in this together to make your own decisions? And is that, do you think, going to trigger more interest in this kind of research? But on the flip side, what if this research reveals that these policies that were established and that were, you know, very clearly enunciated in Canada, that we're not in this together anymore, that everyone make your own risk assessment? What if that research reveals that that was wrong? So is there something at play there? Because the topic is policy, so I think I can ask that. Is there something at play that we may not want to know? And is there something at play that would make us, that make the work that you're doing, all of you amazing researchers, even more relevant given the stage of the pandemic that we're at now?
So I'm going to suggest one person answers, so we've got time for some more questions. So who wants to have a go at that? Molly, is that something you want to have a go at? I'm just dipping you into
that? Yeah, Jeremy, I'll certainly briefly respond to it. Maureen, nice to see you again. I think this is a really fascinating time of the pandemic when we're moving from, as Maureen was introducing them, to maybe the more straightforward regulations, close things down, not allowed to do this, not allowed to do that, to this phase, Maureen, as you've called it, of make your own decisions. And I think currently in Ireland, mask wearing is a fascinating area where this is very relevant. So we have our healthcare professional groups calling for a mask mandate. We have very high levels of COVID in the community, relatively low levels of morbidity associated with it, but high levels of COVID. And we have real problems in health services due to infection control in the hospitals and general health services. So we've healthcare professionals calling for a mask mandate, but we actually have our public health people and our politicians saying, well, it's recommended, but we're not going to mandate it. So there's definitely a real fear of this going back to mandating it. My feeling in Ireland was there was very little resistance to the mandate of mask wearing. There was very high levels of adherence. I think 99% of people are very willing to wear a mask in supermarkets, in public spaces, if they need to. But as soon as the message is, well, you don't really need to do it if you want to, it feels like do it if you want to protect yourself. And it's actually now these people have decided this is not important for the protection of other people. So I would agree, Maureen, that I think there's a fascinating time now, and maybe as a psychologist who's interested in the complexity of human cognition and behavior, this in a way is a more interesting time than the highly effective intervention strategy of making something a very clear black and white regulation.
Great, thanks, Molly. Can I maybe ask John a question? John, one of your concluding trials said that we need to document what we've done, and we need to institutionalize the capacity so we can do, this, continue to do this in the future. But you said one might lead to two. And my concern is that certainly in Canada, there's really not been a great impact of the behavioral stuff. And probably in most countries, it's been suboptimal. Because it's been constrained by all of these sort of factors of funding, of organization, the complexity of the environment. Matti's comment about there being different routes into the government in Finland. So it feels to me we need to build a vision which isn't just what we did, but what we could have done if we had had a better structured, organized system. Do you have any kind of reflections on that?
Difficult question. I mean, I'm just trying to put myself in the position of a decision maker who's saying we're going to put money in this place or this place, and they need to be convinced one way or another that where they're putting their money is going to get a bang for the buck. And I understand what you're saying, that if maybe there was not the success, I don't know how to say it, but could have been, it's very difficult to show that. And that puts you in a very difficult position, because surely there was never a better chance than we've had over the last 2 years to demonstrate the potentials of behavioral and social sciences. And if that opportunity wasn't taken for all sorts of different structural reasons, what a loss. And as you say, maybe what's the way around that, showing what we could have done, but then the decision would sit there and say, well, if it could have been done, why wasn't it done? And then you would say, well, it's because you didn't give us the money. And then it becomes a sort of not particularly helpful back and forth. So I don't really, to be honest, I don't really know what the answer to that question would be, because as I say, I think this was a possibly, hopefully, once in a lifetime career opportunity for showing something. I haven't managed collectively to take that chance. Oof. I mean, I don't want to have another opportunity like this to get that chance. And it seems like that's just a real shame. I don't have a very easy answer to that one, I'm afraid. I don't know. What do you think? What's your thought? What would you like to do about it?
I mean, I think one of the things that we're thinking about in BESSI is thinking beyond the pandemic, but actually sort of trying to talk about infectious disease control. So this isn't just about the 1 in 100 years, hopefully, pandemics, but we have seasonal flu outbreaks. We have regular outbreaks of novavirus or Ebola. There may be a whole range of opportunities that if we could say this is what we could do, but actually during the pandemic, it was hard to actually plan research because to turn it on in the heat of the pandemic was a challenge. But if we think about seasonal outbreaks, they're predictable. We might be able to do research which we could actually start to plan that for 2023, the fall of 2023, across the north, we think about doing something around masking for flu prevention or something else. So I think we have to take it out of the pandemic perspective. I think we probably have to sort of say, we were working from first principles, but if we had got a bit more, if we were able to get more data prospectively, we might have been able to do a lot better. And I think there are examples where people have done A/B testing as they have rolled programs out, which has demonstrated actually, well, just by doing this, we got an extra 2 or 3% points, which at a population level was important. So I think it is a mixture of documenting, it is a mixture of also giving a vision about what might be done in the future and how we have to do that.
If I may just very quickly.
John, last comment because we're at time.
Yeah.
No,
just very quickly to come back on that, just to say, if the pandemic didn't provide the opportunity, there will surely be, exactly as you say, other perhaps smaller events that you can document and show and highlight. And then it's a question of being quite careful and selective about a smaller incident and how we were able to make a difference. And that would be the thing. If that particular opportunity is passed, use other ones, other things that have happened.
Yeah, and maybe we have to think internationally how we actually make a joint argument about that. So it's not just Molly in Ireland or Matti in Finland, but we're actually sort of consistently saying this is where we're at. We're at time. I have to say one comment, which is we didn't get a chance to talk about the methods. And I know if Paul Glasio was on the call, he'd probably be a bit apoplectic about what you said about trials. I think we need to be very Catholic about our methods, and it shouldn't be an either or. It should be an and, because all of these things give us different bits of the puzzle we need to take forward. So I'd like to thank everyone for joining us today. I particularly like to thank John for his presentation, and Ryan and Molly for their contributions, and people for the discussion. You will very shortly see on social media the plans for our next 2 BESSI webinars. I hope you'll be able to join us. But thanks a lot for everyone's time and attention today, and look forward to seeing you next time. John, Marianne, and Molly, I don't know if you want to just stay on the line just for a second so we can debrief, but that was great. Thank you so much. Bye-bye, everyone.
Bye, everyone. Thanks.